Good, good morning, everyone present here. So, the debriefing session will be taken by Dr. Gunadhar Padhi, sir. So, you can start. Over to you. Thank you.
Okay, thanks. Okay. So, yesterday we had
Sir, good morning.
Hi, Dr. Asif. How are you doing? All good.
All good.
They are here. Good. Nice to see you. So, start.
Sana?
So, more candidates are going to join or
Yes,
start?
sir.
More candidates are going to join or should we start?
So, we can start.
So, we can
More
start.
aspirants will be also joining us soon.
Okay, no problem. Thank you. So, yes, so yesterday we had a very good session on the basically the trauma CCS, the critical cases. So, this is a very important topic because what I found yesterday from the
Your
students.
your voice your voice is not clear.
My voice is not
Need
clear.
little louder. Need
My
little
voice.
louder.
Okay. Now it is okay.
Yes, okay.
Now it is okay.
Okay.
Yes. Just a minute. I'll. Yes.
Sir, actually, your voice is breaking.
It is breaking.
Yes, sir. And all
Now
the
it is
other
okay.
aspirants, no, sir, it's breaking. It's actually a little breaking. All the aspirants, it is going to be a very interactive question and answer session plus the theory part. It's a request to kindly any question, any doubt, please text in the chat box, or you can also unmute your mic and ask. Thank you.
Student, this is the debriefing session where if you have any doubt, you can clear your doubt because we have the eminent faculty, Dr. Gunadhar Padhi. He is a very senior consultant in Maharashtra. He is working in HN Reliance Hospital now. So please do interactive.
Yes.
Yeah, continue.
So I request everybody to be interactive. Now it is clear. I stopped my video for the I think network may be fluctuating.
Yes, it's clear.
Clear, right? So yeah. So yesterday we had the session, but I have taken the examination for
Gunadhar,
4 students.
Do you use a headphone? Because sound is not very clear. It is a crackling sound.
Acha. Headphone will be better.
Headphone will be better.
Okay.
So Asif bhai, now it is okay?
Absolutely okay. Absolutely okay.
Yes. Thank you. So without further delay, I'll just we'll start. So yesterday I have taken the examination for 4 students. So what I have realized that most of you are theoretically sound, but when it comes to the practical point, so yeah, you are taking a lot of time. And second thing is mostly we're concentrating on the theoretical part. See, it is a clinical case. So whatever the case is being given to you have to focus on that particular case rather than thinking broadly and about all the different aspects. You have to just focus what you are supposed to do. So this is a very interesting case of polytrauma. So here what will happen, you may be given a case. So this is basically a simple case I have made just to make you aware that this kind of cases may come in the EDIC examination and what the examiner are going to expect from you. So a 46-year-old gentleman, so he has a history of road traffic accidents. So the mode of trauma is very, very important. So why this? Usually with a trauma, they always give the mode of the trauma, whether it is a fall, it is a road traffic accident, it is a head-to-head collision. So that suggests that you have to think that what could be the possible trauma the person will sustain, particularly whether it is a head injury or whether it is a kind of cervical spine injury. So as per that, your plan and management will change. So if you see the mode of injury, particularly it is a road traffic accident, the four-wheeler versus two-wheeler, the collision happens. So in this case, you expect that the person may be having an underlying head injury, plus he may be having a cervical spine injury also. So you'll be very, very careful regarding the cervical spine clearance. So now the patient is drowsy, restless. That again suggestive that this patient is having a moderate grade of head injury might be. He barely follows command. So this can appear in two situations. Either there can be a lucid interval where the person can suffer from extradural hemorrhage or a transient period of restlessness and drowsiness followed by the alertness, or it can be because of the underlying subarachnoid hemorrhage or XDH where the person may be remain drowsy. That's the more important thing that the examiner wants to tells you that this patient is having an underlying head injury. Now, hemodynamics parameter, if you see, so he's definitely the heart rate is high, so it is basically tachycardia is a concerning thing. The patient is having cool periphery. Again, that's suggestive of it's a kind of poor perfusion to all the your peripheral part. His blood pressure is low. So this is a very important point. Any trauma patient who comes to the ER or the casualty with a low blood pressure of 80/40 systolic, he is in shock. No doubt this patient is in shock. So this case is being given as a polytrauma with the shock. So you have to rule out different causes of the shock. And the dictum says that unless until proven otherwise, the shock in a trauma patient is hemorrhagic, hemorrhagic, and hemorrhagic. So the first thing you have to keep in mind where the patient is bleeding. So this is the hemorrhagic hypovolemic shock is the first differential diagnosis. Of course, there are other causes of the shock also, but you have to always rule out the hemorrhage first. So if you see now, if you examine the trauma to the right lower limb, there is a massive swelling and bruising over the right lower limb. So probably he has suffered a trauma to the lower limb, and you know that why this is important, because any trauma which is being sustained over the extremities, torso trauma, that can cause significant amount of blood loss, even if you don't actually find there is external visible hemorrhage, but these patients can lose a lot of blood, particularly pelvic fractures. Any trauma to the lower limb, always suspect pelvic fracture when the patient is in shock. So the pelvic fracture, the patient can lose up to 3 to 4 liters of the blood, and you don't realize this from the outside. That is the reason you have to always do a good pelvic binder. You have to like immobilize the pelvis, and also you have to give the immobilization to the all the limbs, because the femur fracture itself can cause a blood loss of amount to 1.5 to 2 liter. And this bruising also is significant because sometimes you find that there can be multiple underlying compartment syndromes and blood which is getting collected in the muscles, and those can cause a lot of bleeding which is actually not realized. So, and also if you see, this patient also has severe abrasion injury in the abdominal wall on the left and right side of the back, that again suggestive of hollow viscous injury. Any bruising, abrasions, abdominal signs of injury, always rule out splenic and liver laceration, because this patient is hypotensive. So whenever there are blood or there are bruising signs over the abdomen, rule out the hollow viscous injury, but hollow viscous and organ injury, particularly the splenic injury and the liver injury. Okay, so that's why this patient, the history is important, the examination is important, and your assessment is also very, very important. Now, obviously, if you assess the GCS score, this patient has a GCS score of 11/15. Now, GCS alone is not suffice at all. See, whenever this patient comes to you, this patient maybe looks, the GCS may be initially in the range of 11 to 15. You might thinking that this patient may not require intubation, because as per the trauma protocol, the intubation will be required if the GCS goes less than 8. Or, but here, so that is, but the GCS may be down rapidly. That is the reason you have to keep on assessing the patient. And single GCS has actually no meaning unless until you assess the patient every minute, every hourly, or every half an hourly. You do not realize that this patient GCS has dropped, and the GCS drop, it can be significant over a very within 5 to 10 minutes also. So that is why you have to always keep a threshold for intubation. Even if the GCS is 11, you have to preferably keep all the cards for intubation, and you have to tell your juniors and all your colleagues that be ready for the intubation. Now, you have given a 1500 ml fluid, and after the fluid transfusion, it shows partial recovery, and further reading shows still the blood pressure is low. So this is again a very important point. So with fluid, the patient blood pressure is still on the lower side. That again suggestive of ongoing hemorrhage. Okay. So this is a very important point. So whenever you keep all these points in mind, now I have framed the questions just to know that whether you are able to manage a trauma patient as per the protocol or not. This is very important. So I have asked all the candidates. I think only one of them have only answered that recent ATLS guidelines. So you have to stick to the ATLS guidelines, which is called the standard of care, and the recent 11th edition. So before that, you have a 10th edition of ATLS, where they have mentioned that you have to examine the trauma patient in the line of A, B, C, D, and E. So most of you are just uttering word ABC. ABC is not suffice. You have to tell that as per the guidelines A, B, C, D, E. This is the 10th guidelines, ATLS guidelines. But the revised 11th guidelines, only one candidate, I think, Dr. Thomas, she has only told that it's a X, A, B, C, D, E. So always in a bleeding trauma patient, X, A, B, C, D is the first your guidelines. What does X ABCD means? X means exsanguination or stop the bleeding. That is why the ATLS have focused more on the bleeding control. The recent change in guidelines because to primarily focus on the bleeding control. So X ABCD. So X, if you say this X ABCD, you will get the full marks. X ABCD is nothing but it is the exsanguination hemorrhage control. Stop the bleeding, focus on the pressure point to stop the bleeding, then go to the airway, then go to the breathing, then go to circulation. Again, remember that it is not only the airway. In trauma and burns, whenever you are saying it is airway with cervical spine control, always you have to tell this way, airway with cervical spine control, breathing with ventilation, circulation with hemorrhage control, disability with your disability assessment with differential diagnosis, exposure with environmental control. This is how the way the viva should go. Then only you will get the full mark. Otherwise, you may get a 25% mark. You may not get also if the examiner is not in a proper mood. He may not give you the marks also, because these are the strict guidelines as per the ATLS. You cannot deviate from the guidelines. That is why you have to say that as per the 11th edition ATLS, and ATLS is more superior standard of care. There are a lot of trauma guidelines, European guidelines, something called as the your Brain Trauma Foundation guidelines. But for you, I suggest to go to the recent ATLS 11th edition guidelines, which is just recently came up. So in this patient, so how do you manage your plan? So you have to first check, you have to immobilize the pelvis, because for your first priority is to stabilize the pelvis and the long bones. So you have to immobilize the long bones. Do not move the patient. You have to call for the help and immediately immediately stabilize the pelvis. You have to apply tourniquet if the facility is there, and you have to give, if you find any visible bleeding or oozing, you have to immediately apply for the your pressure points application. So they have recommended you can control the bleeding by multiple methods. So one is immobilization, second is by applying tourniquet, third is by applying pressure points, fourth is by applying hemostasis control. Of course, the last is to take the patient to the OT as soon as possible. So in between, you have to, once you are immobilizing his pelvis, you are immobilizing his long bones, then come to the airway. GCS is 11. So this patient is on verge of impending airway obstruction, even if the patient is conscious, but still there is a high probability that he may require intubation. So you have to always assess the airway. You have to examine the airway, oral cavity, ask the name. If the patient is conscious, he may able to tell the name, keep everything ready. If the patient is slightly drowsy, this patient is already drowsy, I would like to still intubate even if the GCS is 11, because this patient is in the verge of collapse because of the shock. So shock itself, your criteria is changed, your intubation criteria has changed because of the presence of the shock. So this patient will definitely require intubation because of the shock, and because of the shock which is not resolved with the fluid resuscitation. So there is a high probability that you may have to take this patient to the operating room. So intubate this patient. In not only intubation, intubate with cervical spine control. This patient, you see the mechanism of injury, probably there is a high likelihood of that this patient may going into cervical spine injury also. There is high chances for cervical spine injury also. So always apply cervical collar, and as per your difficult intubation, your spine intubation, cervical spine intubation protocol, which is called the manual inline stabilization. This word is very important. MIS, manual inline stabilization. The recent 11th edition has changed this wording to drug assisted intubation, DAI. So these things has to be there in your mouth, because otherwise if you water the previous older version, then the examiner may not be happy. So this is called the drug assisted intubation, okay, DAI. Then with your all taking care that the cervical spine should be protected absolutely. If still in doubt, you have to go for the cervical spine clearance. Now, there are different criteria for the cervical spine clearance. I think all of you should read and know about the Canadian cervical spine sees your rule, and second is the nexus criteria. So, which is better over other, and which things you have to assess. So, there are multiple criteria are being laid, starting from the mode of injury, starting from the GCA, starting from the hemodynamics, starting from your cervical spine examination. All these things to take into account, but nexus criteria is a better preferable. So you have to see for the nexus criteria. If there is any spine tenderness, if there is any pain, if the mode of injury is serious, if the patient has ejected from a vehicle, or if the hemodynamics are compromised, always it's assumed that this is a cervical cord compression. You have to apply cervical spine collar during intubation. Preferably, you have to always maintain neck in the neutral position, and go for the drug assisted intubation and rapid sequence induction. Okay, this is what. Second is breathing and ventilation. Put the patient on ventilator in view of shock. Control his breathing. Whenever there is a ventilation, you have to go for lung protective ventilation. Okay, so this is called lung protective ventilation. So as per your lung protective ventilation, you have to ventilate the patient, and then comes your circulation with hemorrhage control. Now, if somebody during this your XABCD, if somebody first have, if somebody says that I will take a rapid to 20 gauge IV cannula, then give a fluid, then you assess the airway, he is not wrong. So that also should be the first standard of care for particularly this patient. So the C can come first before A, B, and D and E. So you can, for this patient, you can change your protocol to a little bit XCA, B, D. Okay, so this is how this situation is that important. So whenever you resuscitate, you have to take proper 20 gauge or your something called as 18 gauge IV cannula if possible. Central lines are not required. Give fluid. Now here again the recent guidelines, what they have focused regarding the fluid. Nobody has told me regarding this. So your fluid management is very important. Now aggressive fluid resuscitation to permissive or something called as the controlled resuscitations concept is now coming into play in the latest 11th edition, where they have suggested not too much of fluid, but adequate fluid resuscitation as per your parameters, blood pressure, hemodynamics, and as per your goal. That is called the goal-directed resuscitation. You have to utter this word, goal-directed resuscitation. So you have to give 30 ml per kg normal saline or ringer lactate. Both are preferable, or balanced crystalloids. If there is a blood, remember this. Always tell, if there is blood is available, you have to immediately give the blood in place of crystalloid, because blood is the standard of care in trauma patient. Whenever you want to resuscitate, immediately alert your blood bank, ask for the blood as soon as possible rather than giving it too much of crystalloid. That is how the C is taking the priority. So after that, you have to go for the something called as disability and differential diagnosis. Nobody has again pointed out regarding the differential diagnosis, but this is very, very important. Now, in the disability assessment, you have to rechecking the GCS, as I have already pointed out. Recheck and recheck, reassess and reassess. Whatever scale you prefer, A, B, APVU, or whatever the scale, the GCS scale you can adopt. You can quick GCS assessment to be done, and always examine the people. Always examine the mental status. Always examine the your neurological status, and before you come to a conclusion. So this is called your repeated assessment of the GCS. Then differential diagnosis. So differential diagnosis means you have to come to what are the causes of the shock in this patient. That is called your differential diagnosis. So in the differential diagnosis, you have to formulate that it may be because the shock may be multifactorial. It can be because of the cardiogenic, it may be because of the hemorrhagic hypovolemic. Second is it may be cardiogenic, it may be obstructive, it may be your something called as distributive. All four kind of shock may be possible. So early inotropic support, and keep in mind regarding all the possible things, then you have to go further. What other investigations you will send? So whenever you tell about the investigations, always focus on blood investigation. You tell in this manner: blood investigation, radiological investigation, and others. So blood investigations, why you want to send and what information you would like to have. So first thing is regarding the complete blood count. So it is very important because sometimes these patients, the hemoglobin may not reflect a true value. That is why you may have to send a CBC, but you have to keep checking on the hemoglobin parameters, because this patient may be hemoconcentrated. Sometimes because of the immediate reaction, they may have a high WBC count. That doesn't mean always infection. And third is platelet. You have to look for the platelet. If the trauma is a prolonged trauma and the patient reaches to hospital after 24 to 48 hours, there is something called as trauma-induced coagulopathy, which may sets in particularly in trauma patient. Okay, you have to go and read what is called trauma-induced coagulopathy and what are the mechanism of action for trauma-induced coagulopathy. Second is regarding the blood glucose, very, very important. Nobody has told me regarding the blood glucose measurement, but any patient who comes to the ER in a shock and GCS is down, check for the blood glucose. This should be the standard of care. Hypoglycemia is always a secondary injury. So your aim here in the trauma is to prevent the secondary injury. That is why you have to maintain normoxia, prevent hypoglycemia and maintain euglycemia between blood sugar of 140 to 180 and prevent hypotension. These are the three things you have to be careful. That is early inotrope, early vasopressors and fluids to maintain a cerebral perfusion pressure and mean arterial pressure, particularly in the range of 65 to 75 is very, very important. If it is a head injury, still you have to go for a little higher MAP. So the recommendation says that if there is isolated injury without head injury, you can maintain a permissive hypotension. Permissive hypotension means you have to maintain a blood pressure in the range of around systolic pressure around 90 or mean arterial pressure around 65. But if it is a head injury or cervical spine injury or spine injury, you have to go for a higher MAP. So higher MAP means you have to maintain the MAP in the range of 75 to 80, or cerebral perfusion or your mean arterial systolic blood pressure in the range of 100 to 110. So why this permissive hypotension concept has come? Because they have been found that if you keep the BP on the higher side in a trauma patient, there can be chances of bleeding from the bleeding vessels. So for the hemorrhage control, this permissive hypotension is very, very important, unless until you have a reason to keep the BP on the higher side. Okay. Second thing is the radiological investigation. Always first go for the bedside radiological investigations or assessment, because you have ultrasound, you have an echo. Just do a focused assessed sonography for the trauma. I think everybody of you know what is a FAST or EFAST. Particularly every trauma patient, unless until proven otherwise, whether they are giving a history of your any blunt trauma to the organs or not, the EFAST should be the standard of care, and it should be done immediately once the patient reaches the primary spot. So that is why the EFAST and 2D echo. 2D echo is just to rule out any cardiac injury, pericardial tamponade, and contractility. Okay, these are the three things. So EFAST will, you know how to do the EFAST. I'm not going to discuss. So all of you should be aware what are the different quadrants you have to check for the EFAST, what are the finding you anticipate, and why it is required. That is why the EFAST is mandatory. Okay. So after that, you have to go for the X-rays. So in this order, you have to go. X-rays, there are 3 X-rays which are mandatory as per the ATLS guidelines. If you suspect cervical spine, you have to go for a cervical spine lateral X-ray. Second is anterior posterior X-ray of the neck. And second is a chest X-ray, which is mandatory in every trauma patient. Third is a pelvic X-ray. This patient has a pelvic injury probably because of the shock. So you have to take 3 X-rays: cervical spine X-ray, your chest X-ray and pelvic X-ray with both the long bones. So that you have to say. Okay, then these all are the primary survey. Okay, and then after primary survey, comes your secondary survey. So what does secondary survey means? So primary survey is to immediately focus on the life-threatening injury. Secondary survey is to focus on the missed injuries. It should be always performed after the primary injury, which constitute a ample history. So ample is allergies, medications, last meal, event leading to the trauma, even leading to the trauma, and of course something the past medical history. So this is called the ample history. This should be immediately taken from the relatives. And second thing is, then you have to go for the secondary survey, which constitute from head to toe examination. Secondary survey means head to toe examination, front and back examination. So I think one or two candidates are only able to tell what is secondary survey. Secondary survey is not to again examine the airway, breathing, circulation or anything. It is from head to toe. So you have to just find out the missed injuries, small missed injuries. So you have to note it down and also do a proper back examination, thoracic spine examination, if unless until otherwise contraindicated, log rolling of the patient to check for the back and check for the groin, check for the scrotum area, check for all the orifices, very, very important. Check for the orifices, anal orifice, your meatal orifice, your mouth cavity again, the nose, okay, any bleeding from the ear, any bleeding from the eyes, all these things should be taken into secondary survey, not in the primary survey. So, and after that comes your tertiary survey. Tertiary survey is a delayed survey. I think none of you have know about what is a tertiary survey, but the tertiary survey is well described in the trauma. So go and read what are the tertiary survey. It is a delayed survey. So up to this, now for this patient, so you have to already intubated, you have to already did a resuscitation job, then you have to already started inotrop for him. You have to already send the blood and blood parameters. You have to already assessed. You had already assessed for the ultrasound and echo. Now the goals of the resuscitation and treatment in a trauma patient is to prevent the secondary injury. Very, very important. So prevent hypotension, prevent hypoxia, prevent hypoglycemia. These are the three things. Okay. And the fifth questions I just put in a theoretical aspect, particularly for this patient, if the examiner asks what are the causes of the shock. So you always tell that the cause of the shock in a trauma patient is first hemorrhagic hypovolemic shock unless until proven otherwise. Hemorrhagic shock unless until proven otherwise. Second is it may be a cardiogenic shock because of the myocardial injury, pericardial tamponade. And third is it can be a obstructive shock because of your pericardial tamponade and pneumothorax, tension pneumothorax. And fourth is something called as a distributive shock. Sometimes the patient can have neurogenic shock because of the spinal cord injury or head injury. Or there may be very, very little chance that they may go into septic shock if the history of the trauma is delayed or it is an open wound. In this way, you have to tell him. How will you proceed further? Now this patient is stabilized, so you have done the investigations. Now, second thing, if the BP is still not coming up, you have to find out the cause of the shock and treat the shock as per the protocols. So up to this, clear? Any questions?
Sir, good morning, sir.
Yeah.
Sir, can we use mnemonics in our answer? Like just now we have used the ample for secondary survey.
Yes, because it is described in ATLS guidelines, which whatever the mnemonics is being described in the ATLS guidelines, you can use it. You cannot use your own mnemonics, but you can use the mnemonics which is being quoted from the ATLS guidelines, and you have to tell the examiner that what is the meaning of the ample.
Second thing, sir, how much we have to restrict ourselves because while describing the primary survey, it may take a lot of time. So that was the confusion yesterday. How much we have to
Yeah.
speak?
See, here I have given you even a broad view. This is a discussion class, but when the questions are that what are the guiding principles and initial management, you have to just tell that as per the recent latest 11th edition of ATLS guidelines for this patient, I would like to go for the X, A, B, C, D, E. I would like to look for the bleeding point and try to control the hemorrhage as far as possible, immobilize the pelvis and immobilize the long bones, check for the airway. I would like to intubate this patient, put them on ventilator with lung protective ventilation strategy. Then before that, already I have started resuscitation with 2 wide bore cannulas, and I had started early noradrenaline to maintain the mean arterial pressure of around 65 to 70. This is what the first thing. Then if the examiner will take you some leading questions, then you discuss. Otherwise, you just restrict yourself to this. What are the investigations? I like to go for the blood investigations. I like to go for the blood sugar check. I like to do a bedside fast 2D echo. And then I like to plan, I like to take 3 X-rays, and then age and when required any investigation in the course of time like CT scan, I will plan. What constitutes the secondary survey? I'll like to take a good history in the form of ample history, which is being discussed in the guidelines, and like to examine this patient from head to toe and rule out any missed injuries. What are the goals of resuscitation and treatment of the care is to prevent the secondary insult in trauma, particularly to avoid hypotension, hypoglycemia, and your hypoxia. What are the differential diagnosis and hemodynamic instability and shock? The cause of the shock in this patient is multifactorial: hemorrhagic shock, hypovolemic shock, cardiogenic shock maybe, obstructive shock I have to rule out if after the fast, and probably distributive shock because this patient is having a head injury component, so he can have possibility of spine injuries and can have distributive shock in the form of neurogenic shock. How will you proceed after stabilization? I would like to take a again check for the shock and treat the cause of the shock after fluid resuscitation and go for the definitive management. This is how you have to restrict. That's why I have framed the timeline to 90 seconds. Preferably it should be 60 seconds. But what I want to highlight regarding your broad aspect, because you have to only tell what examiner wants. You don't have to tell everything, but you have to every possible things in your mind. Correct?
Yeah, thank you, sir.
Yes. Any questions? Right. So these are basically the theoretical part. Just 2 slides. I have trimodal distribution. Everybody should be aware what is trimodal distribution. There are 3 peaks in the trauma: the first peak and second peak and the third peaks. This is regarding the death in the trauma. The first peak usually happens within minutes. Okay, within the minutes. That is why preventing a maximum death happens in the first peak. That is why the preventing the first peak is very, very important, and this is called the golden hour. So the concept of the golden hour comes from there. The first hour of the trauma is called the golden hour. So if you do a good resuscitation, then only the majority of the death in the trauma can be prevented. Now, the recent concept of the ATLS, they have focused on the pre-hospital care. This is most important thing. Pre-hospital care. What is a pre-hospital care? This is pre-hospital care means you have to make things ready for a trauma victim before the patient reaches to the hospital. There are a lot of 3 important trials, major trials, which is being there. If you have time, just go and read all those trials. So they have suggested that you can give pre-hospital administration of tranexamic acid within 3 hours. Nobody has told me yesterday regarding tranexamic acid. This is a major trial which is called CRASH 2 and CRASH 3 trial. That has to be there in your Viva. Otherwise, I think majority of the things then you are going to miss. So this pre-hospital administration of blood and blood products, pre-hospital administration of tranexamic acid has actually changed the trauma outcome quite in a significant way and reduced the mortality rate from 50% to 30%. That is why the ATLS 11th edition has focused on the pre-hospital care. Also, you have to know about the golden hour, which actually the first hour of trauma, and this is usually, yes. Any questions? I'm not able to hear. Okay. So these are this is what the recent change of focus. Okay. So from the pre-hospital care. Okay. So that is why these things are important. So they have now basically more focused on the stop the bleed programs, pre-hospital blood product transfusion, and hybrid trauma base. So what are hybrid trauma base? Basically, every hospital is now coming up with integrated CT plus angio suite plus operating room nearby the ER facility. This is called the hybrid trauma base. This is being described in the ATLS 11th editions. Okay. So now the second thing, now second vignette. So the same patient, now he complains of pain in the left shoulder. This patient is still tachypneic. So basically you just omit the first line. This is, I think this is a mistake, because he got already intubated. He is on ventilator, so these questions are, this thing will not come into the play because you have already intubated this patient. So but the thing is that his saturations are still 92% with you're on ventilator with 100% oxygen, normal breath sounds, but there are barely audible heart sounds, and the blood pressure is still very low. So this is what the scenario is. This was for some candidates I made it. So the blood pressure is still low, and if you find the ABG, the lactates are very high, 8.5, severe metabolic acidosis, low blood pressure, and little lower saturation, and there is a barely audible heart sounds, and you have done a something called as the your 2D echo, and the 2D echo are clearly showing that there is a pericardial collection which is called pericardial tamponade. Never say that it is a pericardial effusion in a trauma patient. So in a trauma patient, this is called pericardial tamponade. Okay, because if the patient is already having a low blood pressure, and these are the echo findings, this is a pericardial tamponade. The ECG also suggestive of same pericardial tamponade, which is called the pulsus alternans. This you have to tell. Two candidates, I think they have failed to answer regarding this ECG. So you have to clear cut tell that this is a pulsus alternans suggestive of pericardial tamponade. So your next plan is to go for pericardiocentesis. So the pericardiocentesis is a bedside procedure. You can involve your cardiologist, but sometimes during urgency, you can take the decisions. You can do a pericardiocentesis by yourself, and you can just put the pericardial catheter, your pictal catheter under the echo guidance. The complications are very, very high, so you have to be very, very careful, particularly the cardiac rupture, the incidence of myocardial perforations, incidence of arrhythmias are very, very high. You have to know and each and every step of pericardiocentesis. Okay, so which place, which point, what view of echo is preferable, what is the direction of your needle, then it should be done under ECG guidance. Even if there is a slight arrhythmias, when the needle touches the heart, you will find there are arrhythmias in the ECG. That time you have to absolutely stop it. Again, readjust your window and again go for the. If your cardiologists are available nearby, it is very well and good. You have to take the help of them. If your cath lab is nearby where you can able to shift the patient, it is still better, because the fluoroscopy guided pericardial tamponade always improves the chances of successful procedure. But if it is not, you can still go for pericardiocentesis in the bedside. It's a bedside procedure. Same patient, you have done the E-fast scan. You can see there is collection around the spleen. There is contusion inside the liver. So there is contusions and splenic lacerations. That is why, in spite of the fluid resuscitation and after pericardial tapping also, this patient is still in persistent shock because there is a secondary organ injury. There are splenic collection, there are liver lacerations, and you can find on the E-fast image of the lungs, you can clearly find there are multiple B lines, and also there are subpulmonary consolidation on the fourth image. These subpulmonary consolidations are underlying lung contusion. So in a trauma patient, you can always anticipate lung contusion, subpulmonary consolidation, and always anticipate that this patient may remain hypoxic in spite of giving them the high FiO2. And
Now, this patient,
yeah,
no, continue.
yeah, okay. Okay, so the why will go into what does the E-fast image suggest? How will you proceed if there is a persistent hemodynamic instability? So even after pericardial tamponade, if there is a persistent hemodynamic instability, that means it is the bleeding from the abdominal organs, as you have seen in the E-fast image. So that is the reason. So you have to always, this E-fast is very, very important. Previously, we used to do what is something called diagnostic peritoneal lavage. So diagnostic peritoneal lavage is not very sensitive, but sometimes if your E-fast or your ultrasound doesn't actually able to come to a conclusion, or if the patient is too unstable to go to a CT scan room, those cases your DPL, the diagnostic peritoneal lavage, can play an important role to rule out any retroperitoneal bleed or any occult injury. But this should not be your first point of in your intervention based on the DPL only. Always do a EFAST, do a ultrasound, bedside ultrasound. If the patient is stable, the literature says that pan CT with trauma protocol, whole body CT scan with trauma protocol improves the survival to 30%. But if it is not, patient is unstable, this patient is already unstable, so patient cannot be shifted to the CT, but you have already got an image on the EFAST. So based on that, you can take a decision for the damage control surgery. But suppose in some cases, the patient may be unstable, the EFAST is not showing anything. Those cases, you can do an EFAST, you can do a DPL. The DPL procedure is, you should be able to know how the diagnostic peritoneal lavage are being done in a trauma patient, and as per that, you can take the decisions. So nowadays, most of the centers, they are practicing modified DPL instead of DPL. This is called diagnostic peritoneal aspirate. So it is particularly helpful in hemodynamically unstable abdominal trauma with a negative EFAST scan. And there is a method to it. So there is a particular in the right lower quadrant, you have to put your needle. You have to first infuse the saline to the peritoneum. Then you have to aspirate the peritoneal fluid. You have to subject the peritoneal fluid for the microscopic examination. If you find that there are RBC's number are quite high, there is a ratio of the RBC to the WBC count, particularly in that DPL sample. Go and read those ratios. If you suggest that there is a significant number of RBCs in the particular diagnostic aspirate, then those patients can be taken to the operating room based on the DPL finding. So basically, DPL is a process where there are abdominal injuries, but which is missed on the ultrasound or EFAST, or patient cannot be subjected to the CT scan. Okay, so this is sometimes very rarely practiced, but you have to, if you say DPL, you have to know how the ideal procedure of DPL and how to interpret the DPL finding also. So this is what is important. So now this patient is being shifted to the operation theater for exploratory laparotomy based on the EFAST image. The operating surgeon find it difficult in salvaging the spleen because there is a grade 4 splenic injury and liver lacerations. The liver injury was managed conservatively. Then he was shifted to the ICU with 2 drains, and during the procedure, he required a lot of blood and blood product transfusion. Yeah.
No voice is
So
coming.
yeah, sorry, it was a little disconnected. So the procedure, he required 30 units of PRBC, so a lot of blood and blood product he has received. That again suggestive of this is something called as he has received massive transfusion. Okay, so the patient can receive massive transfusion in the emergency, or you can activate the massive transfusion protocol in the OT itself. That is why you have to know everything regarding the massive transfusion protocol. Okay, so how to activate the massive transfusion protocol and what are the recent trials regarding the massive transfusion protocols? So there are one very good trial which is called proper trial. Proper trial. So the proper trial has said that the massive transfusion protocol, the ratio of 1:1:1 to ratio of 1:1:2. That means it is like your blood platelets, your platelets, FFP and blood, the ratio of the platelet, FFP and blood. So instead of 1:1:1, if you give 1:1:2, that doesn't actually helps. So this 1:1:1, the blood, one PRBC to one platelet, one to one FFP. Actually, this is shown to be having this more mortality benefit compared to 1:1:2. That is the reason you have to practice 1:1:1 ratio of the your FFP blood and platelets, RBC blood and platelet, RBC, PRBC and platelet and FFP. The ratio to be 1:1:1. Okay, this is how the recent massive transfusion protocol says. So next thing is, what other laboratory and biochemical parameters do you need to monitor apart from blood and blood product transfusions? This is a standard questions. I think you need to monitor every coagulation parameters. So again, so what is massive transfusion protocol? These are all theoretical questions. So go and read from the book. So replacement of one entire blood volume within 24 hours, transfusion of more than 10 units of PRBC in 24 hours, or transfusion of 20 units of more than your something called as more than 4 units of PRBC in 1 hour when ongoing need is there. So how to procedure of massive transfusion protocol, clinical monitoring, how to do. So target resuscitation of massive, all these are the targets. Okay, that is all being described in a standard textbook, more a bit theoretical. Now, once this patient came to the ICU, these are the different bleeding parameters. You can see the hemoglobin is 7.5, the TLC is 21,000, platelets are 43,000, APTT is 67, and INR is 1.6. So this again suggests that all the parameters are being deranged. Okay, so this is something because of the dilutional coagulopathy or DIC kind of picture. So how do you now proceed further? So any patient of trauma, the recent guidelines focused on assessing the coagulation parameters by thromboelastogram or ROTEM. So in the examination, examiner will like to tell you regarding the take. He would like to show different take parameters. So you should be aware of the take parameters. So normally, what is the difference between take and ROTEM? You should also able to know, because now recently a lot of hospitals are being having this machine ROTEM. ROTEM is a better than take. It actually estimate more viscoelastic properties compared to the take. You have to know the difference between the take and ROTEM mechanism. So basically in the take, there is a cup which is rotating, and based on the viscoelastic properties of the blood and the resistance by the cup, you can estimate the coagulation parameters. In the ROTEM, there is a pin which is rotating, and when it rotates, it creates a resistance. And when the resistance is more, it can be plotted in a graph. And as per that, you can able to assess what are the different functional abnormalities in the ROTEM. So you have to know the take component. Take classically consists of R, K, alpha angle, and maximum amplitude, and LY30. These are the 5 components of the take. So R value, K value, alpha angle, maximum amplitude, LY30. In the ROTEM, you have certain other parameters that is particularly your something called as the CF, CFT, alpha, then something called as the MA. So these are the things. And the take, if you see, basically you give products based on these parameters like R value, K value, MA, and angle, and LY30. Whereas in ROTEM, based on this sampling of something called as CF, CFT, then MA, MA30, all these things they were taken into account, and they formulate 4 different kind of parameters, which is called the HAPTEM, XTEM, FIBTEM, INTEM. So how to interpret? So basically the HAPTEM measures your heparin efficiency, the XTEM measures your external coagulation parameter abnormality, your INTEM measures your tissue factors strength and the coagulation parameters abnormality because of the lack of tissue factors. And then how to interpret it. Suppose your haptem is okay, intem is prolonged, extem is okay. Sometimes the extem is prolonged, the intem is okay, and the haptem is okay. All these cases, there are permutation and combination. So you just go and read from the book, because they are going to show you these charts in your EDIC definitely. So these are the normal take charts. One is, you can see the normal take, how does it look like. The second is called the abnormal take, where the R time is prolonged. So the R time can be prolonged because of the anticoagulation effect, factor deficiency, hemophilia. Okay, the 3 is, in the third, you can see the amplitude, the maximum amplitude of the your take test is reduced. So the maximum amplitude actually depends on the platelet. So if the platelets are low, there is thrombocytopenia, your maximum amplitude is reduced. So here you can see the R time is normal, K time is normal, alpha angle is normal, but there is a reduction in the maximum amplitude. So here there is a platelet deficiency. In the first case, there is a coagulation factor deficiency because the R time is prolonged. In the last 4th graph, you can see this is something called as the LY30. Your LY30 is severely abnormal. LY30 means the lysis of the clot after 30 seconds. So here, this is all because of the fibrinolysis. So here, you have to give antifibrinolytics like tranexamic acids. So these are the different your take pictures you should be thorough about. Similarly, go and also look for different your ROTEM pictures from the book, because it is beyond the scope of the discussion. But in a nutshell, I told you what is important and what is not important. Nowadays, always remember they will more focus on the ROTEM rather than the take. Now the days are gone where people used to discuss regarding the take. Now ROTEM is the newer kid in the block. Any doubt? So these are all the take value actually. So how does the take value you interpret, how the value changes, and how the different kind of clot formation happens, how the clot lysis, the other things. Okay, now the next, this patient remained hypotensive overnight. The drains were hemorrhagic. So night duty doctor report, patient is restless, requiring increased doses of sedation, paralysis. Ventilator alarms are continuously buzzing. He has decreased urine output. In the morning labs, you noted that still patient heart rate is severely tachycardic. His HB is low, platelets are low, TLC counts are high. He's having a very high urea creatinine ratio and patient is oliguric. So surprisingly, the X-ray chest is normal. Patient is not having any much oxygen requirement. When you examine the patient, you can find this kind of examination finding. Patient abdomen is usually distended and there are multiple losing spots throughout the drain. X-rays are normal, but the peak pressures and plateau pressures are high because of the distended abdomen. So this patient who returns from the OT after a distended abdomen received multiple blood and blood products and drain is still hemorrhagic. Patient is in DIC, and this patient, if you measure the abdominal girth, abdomen looks quite tense on examination. So probably he is developing a abdominal compartment syndrome. So any patient with abdominal distension with high intra-abdominal pressure along with organ dysfunction is said to have abdominal compartment syndrome. So probably this patient is having abdominal compartment syndrome. So you can measure the abdominal compartment pressure also by means of the Foley's catheter. There is a separate specialized Foley catheter which is available, which you can measure. I'll show you on the CBS station actually. And then as per that, again, you have to decide. So there are medical management, there are surgical management. So what are the different management options? So medically, you have to sedate, ventilate, paralyze the patient, evacuate the bowel, RT aspiration, continuous, put enema, put flatus tube, remove the fluid by RRT, and then surgical management. If in spite of that, the abdominal pressures are still high, you have to take this patient to the OT for further re-exploration, where the abdomen is kept open and there are some pressures like Bogota's bag or some kind of mesh which is applied, and the patient is being shifted to the ICU. So before this, you have planned for a dialysis because you have to remove the extra fluid which is there in the abdominal wall to reduce the edema, and patient is oliguric, the creatinine is high. So you have to plan an RRT. So during the RRT, you have to put an SD catheter, and your junior, when they put an SD catheter, after the procedure is over, the patient is severely hypoxic. His blood pressure further drops and ventilator shows high peak and plateau pressure. So X-ray was being taken, and this is the X-ray. Of course, the patient has developed right side pneumothorax because of the SD catheter insertion. So the point of care treatment here is to put an ICD. Again, so this is a very critical incident happened in your ICU. So the examiner might tend to ask you, how do you counsel the family? What are the critical incident debriefing system you have, or internationally what are adapted? So none of the candidates they are able to answer this, but there is a Mitchell something called as the 7-point your protocols, which is available on the net for the critical incident debriefing. So go and read about the Mitchell's 7-point critical incident debriefing system. It is very new, but sometimes they may ask you. So what are the different points included in this? So Mitchell's model, this is called Mitchell's model, particularly adopted for ICU. So introduction, facts, thoughts, emotions, normalization, and teaching, and re-entry and closure. So the key principles here are, you have to maintain the confidentiality. You have to have no blame, no hierarchy system here. You have to take care of the psychological safety of your juniors and repeated follow-up. What happened to that patient after this, and also follow up with your junior. What about the like one-to-one counseling or any mental health referral will be required or not? Okay. So this is about all about this case. So this case covers your trauma protocol, massive transfusion protocol, your something called as the viscoelastic testing. Then third is your abdominal compartment syndrome. Then fourth is your critical incident debriefing system, and fifth is your something called as the management of the shock. So this five headings this case will run like this. Sometimes you may find that the examiner might take you to some other aspect, like sometimes he may take you to the traumatic brain injury, he may take you to the emergency room thoracotomy, because of the massive bleed, pneumothorax. So everything you cannot describe in the same case. So how do the ED thoracotomy happens? What are the indications? When do you activate? What incisions usually they used to take? So clamshell incision, all those things are again a point of discussion. Sometimes they may focus on severe traumatic brain injury, ICP measures, ICP control policies. So what are the different ICP control agents? Mannitol versus 3% normal saline, which is better. Then how to measure the ICP, different methods to measure the ICP. Then they may take you to the meningitis also. Sometimes the patient may have a ICP shunt and the patient develops meningitis. So what are the, how do you treat it? Then they may take you to the critical illness, neuropathy, myopathy, tracheostomy. Then they may take you to the family counseling. So all this vignette can come in a trauma patient. So it's for the situation that demands you have to go and actually read and then answer is per that way. Any questions? So can we go to CBS? Hello?
So we can continue.
Yeah. Okay. So basically, so what are the newer advancement in the trauma? I'll just give you a like 2 minutes your something called as the focused. So as I already told, first is pre-hospital and system of care. So one is stop the bleed program, pre-hospital blood products, pre-hospital tranexamic acid administration, hybrid trauma base, damage control resuscitation, whole blood resuscitation rather than giving the blood components, then permissive hypotension. One thing what I have not told you here is the RIVOA, resuscitative endovascular balloon occlusion on the aorta in case of major vascular injury, and something called as then exploratory laparotomy and so managing the aortic injury. Coagulopathy monitoring, I already told you, take Rotem. Point of care lactates are now coming more and more. Okay, point of care lactate plus base deficit. Thromboelastography based protocols. Then neurotrauma, particularly you have to go and read for the ICP protocols. Optic nerve shape ultrasound, LED compressive craniotomy trials like rescue ICP trials. Shock, like particularly in the pre-hospital care and tidal CO2 monitoring, they have more focused, which is a field indicator of perfusion and the CPR quality. Lactate guided resuscitation better than the static blood pressure target. Mechanical circulatory support, ECMO can also play a role in case of refractory trauma arrest and the shock. Then thoracic trauma, I already told you regarding the EFAST refinement, clamshell thoracotomy, auto transfusion of chest tube blood, very, very important. Sometimes if the patient is bleeding, you can again give the same chest tube blood after the thoracotomy, which is safe and reduces the transfusion need. Pelvic and extremity trauma, pre-peritoneal pelvic packing plus Ribova, pelvic binder earliest, damage control orthopedics, and your something called as imaging, whole body CT imaging or pan CT per trauma graded protocol, AI assisted triage imaging. The recent ATLS also focus on that. Ultrasound, elastography, and Doppler perfusion scan, and also the newer immunomodulation or immunology in the trauma, particularly the immunomodulation protocol, the metabolic resuscitation like ketone-based metabolism support, and inflammatory profiling like predictors of MODS at risk. Okay, so these are the different, and go and read detail regarding the ATLS 11th edition, focus on particularly the teamwork, critical care thinking, integrated imaging, and also the focus on the mass casualty incident frameworks. So these are called AI-based triage apps and different apps to deliver the blood and blood products. So this is in a nutshell. So now we'll come to the CBS station. So CBS station is, you have to just like answer whatever them being asked in that particular slide, because here one slide only 30 second or 1 minute will be there for you to answer. So without wasting time, just go and just answer the pinpoint like answer to that particular slides or the particular scan or whatever may be asked. So there are 10 slides here. So each slide, the first slide is a 45-year-old man presents with sudden collapse, seizures, low GCS, and this is the CT scan. So you see, so the examiner tends to ask you just tell the CT scan and how do you interpret the CT scan. So but this scan, if you see, this is particularly a scan of subarachnoid hemorrhage. So where you can find the blood in the fissures. So this is a classical subarachnoid hemorrhage with cerebral edema and absence of sulci and gyri. Particularly, you suspect a subarachnoid hemorrhage. So what are the next step? You have to take the patient to the DSA scan. You have to do an DSA and you have to find out it is likely to be a aneurysmal subarachnoid hemorrhage. They may ask you why it is not a traumatic subarachnoid hemorrhage, because the patient can have subarachnoid hemorrhage because of the trauma. So in particularly traumatic subarachnoid hemorrhage, you find there may be underlying fracture. There is a history of trauma, and mostly the location of the bleeding blood is peripheral, not the central. Here, not in the sylvian fissures. If you find the blood in the sylvian fissures, particularly it is aneurysmal SH, not a traumatic SH. The traumatic SH, you find the blood in the peripheral part, and there is underlying bone fracture. That is how it differentiates from the traumatic SH. This is what I want to tell you. So this is the ICP monitoring devices. So right side, you find the ICP monitoring devices. The questions may come from what are the different ICP monitoring devices. So you have to tell them invasive, non-invasive. This is an invasive device. There are a lot of non-invasive device. So invasive device, the preferable is to put a ventricular catheter and level the transducer at the level of the tragus or external auditory meatus at the level of foramen of magnum. Then you have to measure the ICP, and sometimes it may, why intraventricular catheters are preferable, because you can do a therapeutic tapping, therapeutic drainage if you suspect the ICP is high, or you can also have a diagnostic facility where you can monitor the trend of the ICP and you can take the different measures. That is why this is called the your invasive ICP monitoring device. Same in the left side, there are different ICP waves. Everybody should be aware of the different ICP waves. So there are three waves. Basically, something called as the waves which happens because of the cardiac pulsation. These are called the P1, P2, and P3 waves. Sometimes the waves which may reappear in the ICP monitor, which is independent of the cardiac and respiratory pulsations. But these waves can be because of the brain oscillations. So these waves are called the A, B, and C waves. So these are two waves. So these are called the A, B, and C waves, which is because of the brain oscillation, independent of the cardiac pulsation and the respiratory pulsation. But the P1, P2, and P3 waves are more because of the cardiac pulsations. And whenever the ICP goes high, they actually gives you a better idea that the ICP is rising. So this is all because of the cardiac. So P3 is because of the aortic valve closure. P1 is because of the arterial pulsations correlating with your brain pulsation, and P2 is suggestive of brain compliance. So normally, if you see the first graph, the P1 is more than P2, which appears in the dichotic notch, and P3, which actually suggestive of aortic valve closure. Okay, this is the dichotic notch and aortic valve closure. So in health, the P2 is always lesser than the P1, and P3 is always lesser than the P2. When the P2 increases, then when that means the brain compliance rapidly increases, then this is where the ICP increases. So when the P2 is more than P1 and P3, this is called the increase in the intracranial pressure. The last graph you see, you do not find any P1, P2, and P3. So this is a case where there is a severe rise in the ICP, and this is basically the impending herniation. Okay, so when you find this kind of graph in an ICP monitor, this you have to be alert, immediately alert. So the questions may be like, describe the equipments, what is the gold standard of ICP measurement, what are the different BTF guidelines. Go and read what are the BTF guidelines for ICP measurement. All of you have not told me properly. This is very important. There are 4 points of ICP measurement in BTF. Describe all the 3 waveforms, what I have just told you. And now you have to know about the A, B, and C waves. So these are independent of cardiac pulsation but these are because of the brain oscillations. So these are called the Lundberg waves. So Lundberg A waves, Lundberg B waves, and Lundberg C waves. So the Lundberg A waves, particularly when the ICP goes very, very high, this normally doesn't appear. But when the Lundberg A waves remain for a long time, particularly for 5 to 20 minutes, it's suggestive of impending brain herniation. So these 3 waves are all pathological waves. Okay. Before the waves I show you may be a physiological waves, but these A, B, and C waves are always pathological waves. Okay. So the Lundberg A waves, they may last for 5 to 20 minutes, suggestive of impending brain herniation. You have to take immediately ICP control measures. Lundberg B waves, these are the rhythmic spikes of ICP or brain oscillation every 30 to 120 seconds, which is suggestive of cerebral vasospasm. So when there is a cerebral vasospasm or your ICP is slowly rising, you can find these Lundberg B waves. So in those cases, you should take measures to control the vasospasm, the hypertension, hypervolemia, euvolemia, and your euvolemia, hypertension, all those things you have to take the. Okay, then Lundberg C waves is low amplitude oscillations, very, very low amplitude oscillation in ICP every 7 to 15 seconds. That usually represent the normal brain oscillations. So Lundberg C waves may be physiological, okay, may be physiological. That represent your normal brain oscillation. So do not worry about. But if you have to worry about regarding the A wave and B waves. Now this is also a very important diagram. So particularly this is called the optic nerve cell diameter. These are the methods to monitor the intracranial pressure non-invasively. And optic nerve cell diameter measurement is very important because non-invasively you have to measure the intracranial pressure. So the questions may go in different ways. So like how do you measure? So what are the position of the patient? The position should be supine, eyes should be closed. There should not be too much pressure to be applied by the probe, and you have to keep the measurement of both the eyes simultaneously. There should not be any difference between more than 0.5 centimeter, 0.5 millimeter between the optic nerve cell diameter of both the eyes. If it is there asymmetrical, then it is significant. Then what is the absolute value? Don't rely on a single value. You have to monitor the trend every shift. Whenever you suspect there is a rise in ICP, the single value actually doesn't imply anything. This is a very subjective test. You have to know the techniques and how to measure, from where to measure. So once you put the probe, these are the high frequency probes. You have to find the retina, and 3 millimeter from the retina, you can find the largest diameter of the optic nerve here. And at that level, you have to measure the optic nerve cell diameter. Okay. In children and neonate, the normal value should be less than 4.7. In case of adult, if it is more than 5.5 or 5.7 millimeter, or then sorry 5.5 centimeter, it is sorry, I mean to say millimeter, it is suggestive of your severe rise in the ICP. Okay, so more than 5.7 millimeter is suggestive of severe rise in the ICP. And of course, you have to measure the trend. Every time you come, you measure the trend, and that will give you a good idea regarding the optic nerve cell diameter measurement. Okay. So this is what. So the question is, what are the other non-invasive techniques? You have to know about the transcranial Doppler, how to do transcranial Doppler. Everybody should be aware. Okay. Yeah. Now the next CBS, a 54-year-old female. So one or two small points regarding the previous slide is avoid pressure on both the eyelids. Okay, always repeat the measurement. Average of 3 per eye improve the accuracy. You should not do a optic nerve diameter measurement if the patient is having ocular trauma, history of ocular trauma, recent surgery or orbital infection. Okay, and always go for the trend. If the value is more than 5.7 millimeter, it's suggestive of ICP of more than 20 millimeter of mercury. Right. So this is a 54-year-old female.
So can you show the previous slide?
Yeah.
Next.
Yeah.
Next slide, sir.
This one.
Oh, G. Yes. Thank you.
Yes. Yes. Okay. So this is basically this is a simple case of, I'll tell you, a 54-year-old female who present to the emergency department with worsening headache, neck pain, back pain for 2 days duration. She complains of low-grade fevers, chills that developed over the past 24 hours. Her son states that she seems to be more lethargic and has difficulty maintaining her balance. In addition, she reports 3 to 4 episodes of nausea, vomiting, diagnosed to have HIV positive status and was lost to follow-up, presently not on any ART. This is the CSF finding. So you can find that there is a cobweb formation, the proteins are high, glucose is low, CSF pressure is high, white cell counts predominantly lymphocytes. So this case is basically deals with a meningitis. So you have to know everything regarding the meningitis. So what are the different meningitis in different CSF findings? So this particular looks like a viral or tubercular meningitis with a history of immunocompromised status. And second thing is, you have to, how do you proceed? So depending on that, you have to send for the CSF biofire. you have to give empirical antibiotic, empirical antifungal, empirical antiviral, and also your steroids. So steroids always a standard of care in, particularly in before giving antibiotics and to prevent the subdural effusions. Then what are the different causes of meningitis in this patient? Particularly, you can rule out all causes of aseptic meningitis. There are a lot list of aseptic meningitis. Go and read, and always go and read the small things like normal pressure of the CSF, how to do an LP, and what are the different like LP findings, particularly how to measure CSF pressure, and all those things is very, very important. Okay, so these are like to be discussed. So this is an MRI of the spine. So you can find there a complete subluxation of the cervical spine at the level of C5, C6. Okay, so the question is, identify the injury. How will you intubate this patient? I already told you that drug-assisted intubation with manual inline stabilization with taking care of the cervical spine. Complication resulting from such injury, can patient go into complete transaction of the cord and cardiovascular collapse and neurogenic shock? So this is a very simple question, but they may ask you how to do a drug-assisted intubation. What are the drugs? Basically, where to use choline or not? Then modified rapid sequencing drug, what is intubation? How to do it? So all these steps you should be able to know. This is a different question. I just skip this because this is not related to this. Now this is what I want to show you regarding the intra-abdominal pressure monitoring. So go and read regarding all the intra-abdominal pressure monitoring devices. This is a simple Foley catheter, triple lumen Foley catheter, where you can monitor the intra-abdominal pressure, because you have to here it measures the bladder pressure, which is an indirect measure of the intra-abdominal pressure. So you have to transduce at the level of the something called as the symphysis pubis. And again, same, just like ICP monitoring, you have to measure the trend and you have to look for the trend. Okay. So if what are the normal intra-abdominal pressure? If it is going beyond a certain point, it is called intra-abdominal hypertension. And if there is a organ dysfunction, it is called abdominal compartment syndrome, just I have discussed. Okay. So go and read about all those things. They will show you some equipments, particularly in trauma care, which is now recently a lot of newer equipments are being added. So this is a rapid infuser set. The picture A shows a rapid infuser set where you can transfuse the fluid and the blood in a very rapid manner. Okay, so just like not like the normal infuser set, and here you can provision to warm the blood and fluid also, and you can give the fluid and blood in a rapid rate also. So this is called the rapid infuser set. The B is called the cell saver. Cell saver is nothing but it will a kind of auto transfusion machine where the whole automatically the blood from the patient which is being collected in the operating room, it can be again transfused to the patient. This you are using mostly in the cardiac surgery, in the hepatic surgery, in the liver transplants, particularly CABGs, Jehovah's Witness, where we want to save or where we want to have limited blood reserve. The same blood can be auto transfused. So you should be aware of these two machines actually. Okay, rapid transfusion set and the cell saver. So what are the complications of cell saver? I have seen patient getting allergic reaction because of the cell saver. Lot of inflammation is being generated, just like it's a foreign antigenic substance, just like dialyzer. So there can be hemolysis. Sometimes hemolysis, I have seen patients getting hemolysis on cell saver. They can develop rash and other things after they came from the OT. So those are the small questions you may be encountered. So you have to always pre-med them with steroids and Avil, and whenever you suspect such kind of reaction, send the blood flow grouping and cross matching and other things. This is also a new equipment. This is called the Lycox monitoring system. Okay, Lycox monitoring is nothing but this is called the brain tissue oxygen monitor. Okay, so this is a very minimally invasive like probe is there, where you can implant those probes. There are catheters which are called the Lycox catheter, and these catheters are directly connected to the transducer of the Lycox monitor. And once you put the probe, they will measure the regional oxygen tension at that particular area, and you will find a value which is normally vary from 30 to 60. So the brain SpO2 or PbTO2, this is called the PbTO2. Okay, so how do you interpret the results are very important. So the interpretation is always based on the saturation. If the saturation is low, body saturation is low, PbTO2 is low, that means it is a global hypoxia. But if your body saturation is normal, but the regional saturation of the brain is low, that means that particular, it is called ischemia of that particular area. So in those cases, you have to take measure to prevent ischemia. You have to take measures to increase hemoglobin. You have to take measures for any decompressive craniotomy, if at all, measures to control the cerebral edema. Similarly, if the body saturation is normal and the PbTO2 is also more than 30, then there is no problem in the regional hypoxia mechanism of the brain, or there is no ischemia per se. So in a particular head injury patient where you want to monitor the regional circulation, this PbTO2 is a great help, but sometimes this probe, you have to ideally place it. Sometimes this probe may be like not properly placed. Those cases you have to always recheck for the probe placement, because these are very lighter instruments, the probes. So sometimes they may come out from the particular placement point. So those cases you have to be instruct your staff to look for check for the probe placement at a regular interval. Okay, then only you can able to interpret the results in a better way. Then also the examiner might show you different newer gadgets like Riboba, what just now I have discussed, resuscitative endovascular balloon uh, tamponade. That is also a newer device where in case of suspected aortic injury, you can just put the Riboba balloon. You can inflate the balloon and stop the bleeding from the aorta till the time the patient is being taken to the operating room and re-exploration is done and aortic repair is being done. So these are all life-saving, you can say, the instruments now, particularly in the trauma. So go and read about all these things. Okay. So this is all regarding the trauma. So this is the brain tissue oxygen monitoring system, integrated Lycox. Okay, so though trauma looks very simple, but I can assure you that it's a big topic. Okay, so go and read the different salient points. Any questions?
Thank you, sir. To all the aspirants, the next debriefing session we have at 5 p.m. IST. Please do join that session. Thank you.
Uh,
Okay, thank you all.
Excuse me.
Yeah,
Hello, sir.
yes.
Sir, I was trying to download the newer guideline of the ATLS, but I was unable to. Can you share the, if you have, if possible for you?
Yeah, sure, definitely. I'll send it to
Thank
Dr.
you, sir.
Asif. He will share with you all.
Okay, sir. Thank you, sir.
Gunadhar,
Yeah.
my request, if you can send the ATLS guideline 11
Yeah.
PDF, then I can share with
Please
the
send it
student in the
to
group.
that first group only. Hanji.
Sure,
Yeah.
definitely. I'll
Thank
definitely
Thank
send it.
you. Thank you, Gunadhar. It is a very informative and elaborating uh, topic. You have covered well. And the student, the trauma and the neuro, this is CNS, one of the important core area for the EDIC exam. Either it can be come with the CBS, or you can get the long case or short case in the CCS. So uh, wish you a very happy Sunday and best of luck for your exam. And thank you, Gunadhar. Thank you to take burden for us.
Thank you and all the best for your exams.